All right, well, welcome. Welcome today. My name is Felicia Saracino, and I'm the Director of Business Development here at Oakton Place at the Arlington. Today on Live with a Purpose, we have an educational event discussing post-acute preparedness with COVID-19, and we have a group of expert panelists here for you. Our panelists today include Dr. Brus. He is our Medical Director here at the Arlington. We also have Colleen Ferren. She's the Director of Rehabilitation at Trilogy Home Health Services. We also have Joanne Leary, Director of Case Management at My Care Manager, and Chechilo, Director of Business Development at Comfort Keepers. Welcome to everyone. Thank you so much for joining us today and also for being a panelist on our event. I'm going to turn it over to Dr. Brus, who's going to discuss a little bit more in depth of what's post-acute care and what does that mean.
Okay, great. Thank you, Felicia, and welcome everybody. Good morning. I guess to talk about post-acute care, we should probably talk about what acute care is for those that do not know. So acute care is hospital-level care. Being admitted to a hospital for any number of reasons. Could be due to an illness, could be injury, could be elective surgery. Following that hospitalization, if more care is needed to recuperate, that's where you would be considered now in the post-acute care space. The Arlington is a post-acute care facility. Some people know it as skilled nursing facilities. Other people refer to them as rehabilitation facilities. It's a place where you go following your acute care, following your hospitalization, to continue the healing process, to continue to get better and stronger in that transition back to home. As I said, you could be hospitalized for any number of reasons. One of the more common things that we see in skilled nursing care, especially here at the Arlington, would be elective surgery. So an example would be that you go to the hospital, you have a knee replacement due to an arthritic condition. But at that time of discharge from the hospital, you're not quite ready to go home. You still need additional care. You will then be transitioned into the post-acute care space or setting, I guess I should say, for ongoing care before you're ready to go home. People can consider also assisted living as part of the post-acute care space. The group that I work for, Team Health, our post-acute care team encompasses care in those levels of care as well. So skilled nursing care, but also assisted living care. If you're not quite ready to go back home and you still need some assistance following that initial hospitalization, that's what this setting is for.
Wonderful. Thank you so much. So I would like to have each of our specialties here talk about your role with the discharge planning and patients for your specialty. So I'd love to have Joanne talk a little bit about geriatric care management.
Okay. Welcome everyone. Felicia, thank you for the opportunity. So I am based in Naples. We see people from basically Fort Myers to Marco Island. And our job is we do a comprehensive assessment and we manage their medical needs. We sometimes manage their household needs. It's really to promote the highest level of functioning that people can have. And so usually what we find in the aging population is that people need advocates because the system is so confusing. So in this particular case, when we have one of our clients and they're in the hospital, we talk to the discharge planner. What are they recommending? We try to make sure we're setting up those options at home. I can tell you what their last rehab was, because generally people like to go back to the same place they had rehab before. I can tell them who was their last home health company they use. Sometimes they're coming home, the therapy is going to be in the home, but we need to supplement that with home care. That would be what Rich is talking about. And my job is to coordinate all those services, get those people involved. So I look at the big picture. My goal is really to set people up for success. And then if there is a crisis, is then to manage the crisis once it happens. So that is in a nutshell what I do. And I will tell you that in the COVID world, post-COVID, things look a lot different now. Usually if someone's in the hospital, I'm right in the hospital. I'm making sure they have what they need. I am talking face-to-face with the nurse, face-to-face. Now everything's done over the phone. We are not going into the hospitals. Usually we follow the people to rehab, making sure they're getting all their needs met. We are not doing that anymore now. So we're doing, we're keeping in touch and advocating for the person, but it's mostly by phone now or telemedicine is how things have changed for us.
Wonderful. Okay. And next I'm going to have Rich Chechilo from Comfort Keepers talk about some private duty care.
So our role in the post-acute preparedness is basically transitioning the patient to the home setting and making sure that they have everything that they need to be comfortable at home. And a lot of that, you know, probably our most popular program is called our Home Sweet Home package. And what that package is we will actually come pick the patient up at the hospital, at the rehab facility, take them home, and then proceed to spend the next 4 hours with them, cleaning out their fridge, you know, if they've been in the hospital for a while, booking their follow-up appointments, picking up their prescriptions for them, making sure that they take their medications. Not managing the medications, because that's Joanne. But for us, it would be more medication reminders. And basically, it's just making sure that, you know, hospitals don't want those readmissions. So basically what we're trying to do is we're trying to make sure that during their most vulnerable time, that we're there to support them, we're there to be there for them, and we're there to make sure that they don't have a fall, to make sure that their transition from the hospital is a smooth one.
Wonderful, wonderful. Thank you so much, Rich. And now I'm going to have Colleen Ferren from Trilogy talk about home health services.
Hi, good morning. Can everyone hear me okay?
Yes.
Thank you so much for this opportunity. Trilogy Home Health Care is a fully certified Medicare agency. We cover the state of Florida, save for the Panhandle and Dade County. My particular position is a rehab manager, but I'm here to speak to the breadth of what Medicare home health services are. We are a skilled provider. So we send in skilled nursing, be that a med-surg nurse or a certified psychiatric nurse. We send in physical therapists, occupational therapists, speech language therapists, social work services, and non-skilled aid services, providing we're being covered under the Part A benefit. Right now in the COVID world, like all of you have just indicated, things have been turned upside down. Medicare has let loose binding restrictions that have been in place for 65 years. I know I'll have a little bit more of an opportunity to talk about that, but we literally are the extension of your acute care services. Our nurses provide IVs, our nurses do injections, our nurses do complicated wound care. We provide all means of specialized therapy services in the home. So this is an extension of the care plan that came from the hospital, that came from the skilled nursing facility, that came from a long-term acute care facility, that came from an inpatient rehab services, and we are just doing it in the home as skilled services there. It is a benefit that Medicare has been generous with over the years. If it's a Part A provider, there is no copay, and that has stayed in place. So that's the differentiation, if you will, between what Joanne and what Rich did.
Wonderful. Thank you very much. And Dr. Brus, now that COVID is here and skilled, with our skilled community, how is discharging our patients now changed a little bit more? Because I know there's a lot more protocols put into place.
Yes, as far as the skilled nursing space, obviously there has been a lot of changes due to the pandemic. As far as the discharge plan, that hasn't changed all that much, other than obviously coordinating with our home care teams, getting the patients back out into into that space, into their homes. The challenge though is from my perspective, is that follow-up piece, getting back out to see your physicians, to see your specialists, for the care that you may need has been tricky. As many have mentioned, a lot now is being done either via telephone or telephonically or Zoom like we are on today because of the concern of infection. So the post-acute or the post-skilled piece that everyone else has just mentioned has become even more important now because of the I don't want to say lack of accessibility to the medical teams in the outpatient setting, but because of all the new restrictions and concerns that are out there, we're trying to keep people in their homes and safe in their homes with the least exposure possible, the least risk to developing a potential problem with the infection.
That's wonderful. And is there anything else that any one of you would like to add about how COVID has changed your direct focus and how your patients are being cared for at this time?
I'm happy to address that if you would like.
Sure.
The home care world has always been very, very mindful of infection control. As you know, anyone that has read a newspaper, has looked at television, there were huge issues initially trying to make sure that we had all our supplies. And I have to say, knock on wood, we as a company did very well marshaling our resources. We had N95 mask fittings, we had adequate supplies, we did a very good job. What we found were that many patients, new and old, were fearful of having people in the home. There was a real over concern that there might be contagions. The invisible menace was available to them. So what has happened is we either kept people that were very fragile for a much longer time, if they continued to allow us to come into their home, or we ended up discharging people that weren't quite ready yet. And I think that from a home health perspective, what concerns me the most about this is our patients have had less access to services that they needed to stay healthy. We know that the ER visits nationally are down all over. We know that access and choices to go see physicians, to follow up with surgeries, all of that was put on hold for a while. It's slowly being reinstituted. But what I'm seeing are sicker patients. What I'm seeing are patients that have more needs right now. So we're trying to address a population of people for whom one size does not fit all any longer. So it's challenging. It's been quite an event, and it isn't over. So we're still working on it.
That's right. Sure. I know, Rich, I'd like to have you touch base a little bit on how Comfort Keepers really prepared for taking on some COVID patients.
Yeah, and like Colleen, we did our due diligence with the PPE equipment that we needed to have. We were blessed that Collier Emergency Services was able to provide us with gowns and masks and gloves and all the proper PPE equipment to handle COVID-19 patients. So we've have dedicated caregivers who are strictly used just for COVID-19 patients. So that way that they don't have any type of contact with any non-COVID-19 patients. And we've been doing that for probably at least the last 2 months now. We strive to be what people need us to be, and we felt that there was a need for home care to be able to take care of some of these patients at their most vulnerable times. And when COVID-19 first happened, we saw a little bit of a dip, like Colleen said. People were fearful of having someone in the home. And now we've seen a resurgence of that as people, and Colleen, you alluded to this as well, as people's conditions have gotten, worse and have deteriorated. They've now especially needed home care and have needed somebody in the home with them now. So it's been a roller coaster, to say the least. But I'm very proud of the work that Comfort Keepers is doing to help those in need during this difficult time.
That's terrific. And I'm going to switch over to Joanne. Can you explain to us a little bit more on what the difference is between an observation stay an admission stay in the hospital and how that affects that post-acute care decision.
Sure. I'm going to tell you what it usually is and then tell you the changes they made because of COVID. So basically, when you get into the emergency room, they have a choice. They can admit you or they can keep you observational status. So one of the things as a care manager we would do is we want to know, is this going to be an admission or is this observation stay? Sometimes they know right away, sometimes they don't. The difference is with an observational stay, it's paid by Medicare Part B. And what's important to that is that there'd be a 20% copay after your deductible that would need to either come from another private insurance if you have Medicare, or would have to be paid out of pocket. Whereas an admission is your acute Part A, which is what would happen if you went over to home health like Colleen. Additionally, if you wanted to go to a skilled nursing facility or you wanted this intense care afterwards, there was a 3-day stay that you needed to, inpatient stay that you would need to make in order for Medicare then to cover your post-acute care. Because of COVID, they've waived that so that they are not requiring that. I think they're trying to do the best keeping their people in the hospital shortest time as possible. And what's note, when COVID first came out, we went to all of our clients' primary care physician and said to them, what do you want us to monitor for? What extra steps do you want us to take? How would you manage it if our clients started showing symptoms? And almost across the board, they really don't want people in the hospital unless the hospital can do something that is significant to make them better. That is for people living at home with support. I know there's different rules that if you're in a assisted living or a memory care unit, but so then our job was to make sure that everyone had the equipment that they needed for the clients. I do have clients where doctor's appointments are non-negotiable. So if you have a cancer diagnosis and you need radiation, you can't do that through the telephone. You can't do it through Zoom. Pain management, those people who are getting injections, you can't do that. So those people, everything's changed. So everyone needed to wear a mask going on. Everyone needed their temperature changed. They were making sure that people weren't exposed before they let them in. Most people, not all, most doctors' offices do not have waiting rooms anymore. You're taken right back. So it is a different world right now.
Absolutely, that's very true. And Dr. Brus, I know we talked about COVID within the skilled nursing community. Can you tell us what we do here at the Arlington to ensure that we've taken extra precautions for our patients coming into skilled?
So we are working with our hospital partners very closely, and we have been able to now have everybody tested before they come into skilled nursing care from the hospital. They do have a COVID test, a rapid test the day of discharge prior to coming into the facility. So we've been very fortunate in working with our hospital partners to ensure at least that aspect of their care. And then certainly we are following all CDC protocols and state protocols here within the facility. We do have an admission unit. One of our floors is our admission floor. So everyone that comes in from the outside, from the hospital, gets admitted to that floor. They are on that floor for 14 days. If their stay is less than 14 days, they go home. If their stay in skilled care is beyond those 14 days, we then move them off of the admission unit to our third floor. Again, as much as we can do to eliminate or mitigate that risk, we are implementing here at the facility.
That's wonderful. And Rich, can you tell me a little bit more about safety measures and the prevention of COVID-19 spread within a home atmosphere?
Sure. It's doing your due diligence with cleaning. It's being meticulous. It's, like I was talking to a friend of mine who said, she takes her shoes off before she gets into the house. She's wiping down her counters as soon as as soon as she gets into the house. It's being making sure that you're washing your hands after you've been outside. It's like I said, it's just doing your due diligence and making sure you're disinfecting, you're cleaning every time that you leave your house and you come back in. You're washing your hands, you're doing your due diligence with that. It's just being, more attention to detail than in the past. I mean, I think we've all washed our hands. I think we've all had good hygiene, but what we've realized is we've gotten careless at times, and we haven't, and now it's just dotting the I's and crossing the T's and making sure that, you're staying clean and you're keeping your environment safe for anybody else that's going to be, sharing that environment with you.
That's very true. Thank you for that. And Colleen, can you talk a little bit more about what does homebound mean and how does someone become eligible to receive services from Trilogy?
Sure. I alluded earlier to the fact that CMS has loosened restrictions that had been in place for 65 years. And part of that has to do with how we qualify now for homebound status, how we qualify for home health, and who can be the certifying clinician. So for starters, in order to qualify for home health, one has to be homebound. When I say homebound, our traditional definition is considerable and taxing effort. However, what CMS did, and I'm going to read it from the regs right now, is during this pandemic, they have said that someone is considered homebound if the physician or their certifying clinician advises them not to leave the home because of a confirmed or suspected COVID-19 diagnosis, or if the patient has a condition that makes them more susceptible to contact COVID. This is the very first time that we have had an inclusion like that in homebound. Homebound generally means considerable and taxing. What that means is that I can't leave the home without assistance because I either need physical assistance, emotional support, or cognitively I have impairment, or I have something that causes me to be at risk. I'm immunocompromised and going out into the community would risk me. So we have opened that up. The other qualifiers include making sure that we have a certifying clinician, and instead of, for the past 65 years, that being just a physician, for the first time and now going forward, ARNPs, NPs, and PAs. So clinicians that are traditionally under the supervision of physicians have now been given the authority to certify the cases, to give the orders, to sign for all of that. That started as of March 1st. And that works for us so long as those clinicians, those nurse practitioners and physician's assistants, are registered in the system, that they have their own PCOS number and an NPI number, which behind the scenes allows us to access and to bill Medicare for that. The other thing that for the very first time we've been able to do is, in order to satisfy something called the face-to-face qualification, which is that the certifying clinician or physician has seen this patient, has said that they have a homebound status, they have diagnoses that warrant the care, we can now do that through telehealth. It has to be both video and it has to be both audio. And I have to tell you, that has sped up the process of what was a laborious paper trail for years. And any of you, the doctor is smiling, any of you know that it's been horrendous. This is lickety split. So we have been very happy about that. So telehealth for face-to-face, more access to clinicians, and now we have parity among all of our disciplines, nursing, PT, OT, and ST, that they can all be qualifying clinicians. They can all skill and help a person get on service, which again opened up the breadth of patients that we can take. And if I may, to go down a squirrel hole for a second, I just want to dovetail on what we're doing to keep people safe. Our offices have been testing any clinicians that come in. We've been making access to the COVID test a real priority. We also are temp taking daily the clinicians that are in the field. so that we're monitoring should anything happen, much like you would with your skilled facilities or your assisted or independent living facilities, that any of your potential employees have infections. So we've looked at that big picture. We have taken care of bag technique. I think people are dreaming about how wonderful their bag technique is now, because we've really gone the extra effort.
Yeah.
Thank you.
That's true. That's very true. So I'm going to go over to Joanne, and we're going to talk a little bit about what's the difference between home care and home health. They get confused a lot, and it's pretty easy. You know, it's simple.
Okay. So let's say I go in and I do a assessment, and every assessment is individualized, and you find out the person needs more day-to-day help, whether it is supervision for safety, or whether it's that you found out that they haven't been eating because they can no longer really cook a meal, or they're getting confused. That is rich. That is hands-on direct care. And that most times that's an ongoing need, and that that you're filling. And you're filling that need so the person can be successful where they are. A lot of times, and I know this is true at the Arlington, there are people in independent living that they really border, should they be in assisted living? But if you can bring on that direct hands-on care, or that added supervision, or add that little bit of support, they then can stay longer in independent care. And so Rich's long-term, his people are direct hands-on care. Now, if someone's falling a lot, if someone they have come out from the hospital, or they've come out from a acute or subacute rehab stay, and they need more PT, they need more OT, then we would go to Colleen. Or they're coming home and they need a skilled nursing, they have a skilled nursing need that only really a nurse can do, but they're not sick enough to stay in the hospital. That would be Colleen. And it's a generic statement to say that Colleen's services, the home health, that is paid for generally by Medicare or your private insurance, whereas Rich would be out of pocket, or sometimes long-term care insurance. That generally Colleen is a short-term need, that once the person, with some exceptions, stops making progress, or they no longer have that need for service, Colleen's service would then come out. And both Colleen or Rich, if you feel like
May I glom on to that for a second?
Absolutely.
One of the things that I'm able to do as a rehab director is we have maintenance therapy services.
You do.
There are very few home health companies that have ventured into that. And what that means is those patients that have neurogenic conditions, those patients that have considerable functional impairments that become a round robin, it's a circulating door of coming on and off services. We keep on services. So our PTs, OTs, or STs go in once a week for as long as they need it and provide a maintenance level care. That is one different thing. For nursing perspective, I think that right now we're keeping people on longer because we don't have a place to send them.
Yeah.
Right? We're doing more IVs in the home than we did. The wound care, they can't get to the wound care clinic like they used to. So we're taking each case individually that way. But you're right, in the big picture, in the gestalt, it is much more of a short-term care experience.
That's true. Thank you both for that. And so I'm going to move on to Rich. And can you just touch base about how your services and home care can partner with other providers in the industry, such as assisted living, memory care, or independent living?
Yeah, absolutely. About 80% of our business is in the home, but about 20% of our business is at facilities as well. And we do partner up with a lot of facilities, not only doing staffing, but also helping, like you said, we use the example in independent living. You know, those people, you want to keep them as independent for as long as possible. And we can help do it. We can help that by just coming in maybe a couple of times a week and just helping them with some errands and light housekeeping, or some meal prep, or some transportation. Maybe it's just they have issues getting to and from doctor appointments, things like that. So we can come in and kind of keep people at a specific place without them having to go, without them having to move on. And we can provide that in memory care. We can provide that in assisted living. We can provide that in independent living as well. As you know, even in assisted living, there's not always that 1-to-1 ratio where they have somebody looking at them 24/7. And some people need a little bit more, a little bit more attention paid to them because they are at risk. So we can kind of, like I say, we kind of fill in the gaps.
That's true. Very true.
Yeah.
Sometimes just that companionship.
Yeah, and we fill in the gaps. Colleen does her thing, and Joanne does her thing, and then there are gaps in between, and we kind of come in and we fill those gaps, so that way you have your complete continuum of care.
Fantastic, thank you. I'm gonna go back over to Colleen. Can you talk a little bit more about what that Medicare waiver is, and a little bit touch base, just a tiny bit, on Medicare benefits for post-acute, and also the different, a little bit on if you have insurance plans, like how those differ?
So the waiver world doesn't really affect home health. It isn't like hospitals in a 3-day stay to a SNF. What I had described before is the loosening of rigid regulations is probably the most prominent thing that has affected us. We don't have any sort of criteria that the hospital needs to meet or the skill needs to meet in order to admit someone to home health. They can be admitted to home health so long as a certifying clinician says that they need the services and we need to provide skill. The other thing is, if I may for a second, what I have not heard, and I just want to bring up, is the affective, emotional issues that have come out of this. I have not talked to a clinician, nor have I talked to a patient with any sort of phone contact that hasn't told me about their anxiety, their fears, their insomnia, their weakness, etc. One of the things that we do is we provide psych services in the home. So for those patients that are having adjustment reactions, that are lonely. I mean, yesterday I read an article in Newsweek, the Alzheimer's Association website. I could not believe this one. It was National Geographic, and a couple days ago on the New York Times, about the effect of all of this on people with cognitive issues, on people with dementia, right? The lack of access to their family members, their caregivers. I heard stories about ALs on my coast, assisted livings, where people have been bound in their room. They can't go to the dining room. They're drinking too much. They're depressed. They're sad. So one of the things that we're trying to do is to get out there to support the families, to make contact, to see if we can't facilitate some attention to how they're feeling about this, right? Their emotional tone. And then lastly, we are a Medicare certified provider. We take just a handful of private insurances, but in the world of skilled home health therapy, many companies do. Each insurance company has its own criteria, each insurance company in terms of what they're going to pay, how many visits they get, whether you're going to get 6, whether you're going to get 15. So what happens when all of us is when patients are admitted to service, we have to dig down into the details and see just what kind of access they have, what kind of resources we have to provide care. Did I answer your question?
Absolutely, great, thank you.
Okay.
I'm going to switch over to Dr. Brus. What, in your opinion, are a couple of questions that if someone is looking for a skilled nursing facility would be great for someone to ask, and how to choose a skilled nursing?
Well, I mean, making sure that the skilled nursing facility can meet their needs, I think is probably, the most important thing. The reason that you're in the hospital, the reason that you're requiring the skilled nursing care, if it's rehabilitation and therapy, making sure that you're comfortable with the therapy team at the facility. If it's wound care, making sure that they have wound care services at the facility. A lot of times it's just proximity to their home. They feel comfortable knowing that they're closer to their home, to their loved ones, to their friends. All of those play a role. Skilled facilities are, for the most part, they offer all of these services. Some facilities obviously do them better than others. A lot of people also use the CMS website for their star ratings as well. Keep in mind, those things are not as accurate as a lot of people want to think they are. There is a 3-month lag in the reporting that goes into what makes a star rating. So I certainly wouldn't put as much weight on that. A lot of it is word of mouth. I've been to this facility. I do enjoy the teams there. They made me comfortable. And again, obviously, you're there for medical care as well. So certainly the medical services at the facility are important in that decision-making process.
That's true. And here at the Arlington, we actually are doing some virtual tours for folks if they want to take a look at our skilled community. And so you could always ask others too in the area if they would do that for you to make you feel comfortable. So now we're going to move on to some question and answers for everyone. I have a couple here that were sent to me. We are also streaming live on Facebook, so I have some there. But does anyone in the group have any questions before I ask those coming from Facebook? I can unmute you if you raise your hand. And in the meantime, while we do that, or you can send me a private message. I do have a couple of questions coming in. One came in from Facebook on what is the future of telehealth? So
I'm in favor of it.
And I foresee that this is going to be here for the long haul a little bit, but what does the group think on that?
I'll jump in there for a second. As a clinician, as we have mentioned, right now in this pandemic state, telemedicine certainly is an important adjuvant to medical care. However, in my opinion, it has its limitations. As one of the panelists, I forgot who it was, had said, sometimes there is no alternative to actually being in a physician's office. Sometimes there is no alternative to actually being able to physically examine, being face-to-face with that patient. Right now, it is an important part of our medical care, forced upon us, I think, by this pandemic. But going forward, it certainly will play a role, but it will never replace the face-to-face visit with a clinician, whether a physician or an extender or another healthcare provider. But again, I see it as an adjuvant to those visits. It certainly can make medical care much more accessible and easier, but there are just times where you need to be in the presence of the clinician to make the proper medical decisions.
That's true. Very good point.
I'd like to add a little bit of that. I've seen it done well, and I've seen it done very poorly. Part of it depends on the person, on the patient or the client, how comfortable they are with technology. I had a session where I was with the client because they couldn't manipulate. The connection was terrible. She could not get what she needed out of it. And so she insisted the next one had to be face-to-face. It was an important appointment. Other times I've seen people not wanting to leave the house because they're nervous, and it was the direct contact, and it made the difference with the doctor to make sure that they were monitoring what was going on with the client. So I've seen it done both ways. I think it's here for a while, but I do think that it's not going to replace the face-to-face in the long term, but it will be here for a little bit longer. Well, probably for a lot longer, actually.
That's true. Anyone else want to add to that before we go on to our next question?
In the home care world, we cannot bill for any telehealth services. So even if I have an access to an app, and we have an app called Cinzy that some of our nurses use, that I can talk to my patient, I can use that for documentation purposes, but I can't use that for any billing. Home health is not allowing that. I like telehealth, like I said, because I'm being very selfish. It's an easy way for me to get access to papers that I need in order to process claims. The other thing that I have seen more and more is interdisciplinary. My nurses can go out and they can show the physician on the phone or on the telehealth what the wound looks like for that person for whom getting into the clinic is very difficult. So you have a skilled clinician communicating with a skilled clinician that way. So that has been very helpful. I think it's here to stay. I think that, like Doctor said, and certainly everyone else, that it's not going to replace anything, but I think that it definitely is going to embellish on what we're doing now.
Okay, that makes sense. And I do have a question from David from our audience. How is everyone handling COVID testing, taking the test, reading the test, and billing for it?
We are just assuming we're assuming all the costs for all of our clinicians. There are many facilities, very many communities, that in order to get in, the clinician has to have a recent test or paper result in order to show someone. So we're just absorbing all of that cost.
Wow. Okay.
And we are testing, all of our caregivers are mandatory testing. So all of our employees, and since we are an agency that includes our 350 plus caregivers, all have to be tested. So
okay.
they've all been tested.
Okay. What about the patients and you're in the homes that you're caring for? Are you testing those as well?
We're not testing those, but we do have them. They are having to answer a series of daily questions. You know, have you traveled outside of Florida? Have you been in an airport? Do you present any of the following symptoms? So we're doing basically like a daily check-in for all of our patients.
Same thing. If a client wanted a test, we would arrange to make sure that they have it. But most of the caregivers in our homes, they're taking the temperature. Some cases they're taking their oxygen level. They're monitoring symptoms, looking for some of the telltale signs of shortness of breath or a cough or some of the other symptoms that manage. But what I have personally found, we had a caregiver that possibly could have been exposed, and she had testing, and it took us a while to get the test results back. And so that, I'm hoping that system is a little bit tighter moving forward, and they did identify that it was a certain lab, but I know that could be a problem for some people because this caregiver couldn't work until the results were back.
Right. And like Rick said, we have a COVID-19 screening tool that we use as well. I find that our directors of clinical services in the offices are constantly staying on top of the county websites to find out who has quick testing, where they can go. It's much better now that some of the Walmarts and the Walgreens and the CVS's, there's more access to that. But the patients ask about it certainly a lot. They're interested. The other thing is, when we get patients discharged from the hospitals are all testing. So we know that the patient coming home, at least on that day, did not have a positive result.
The ERs are testing also.
There you go. Just walk in. You can just walk in and get tested.
I had someone that wasn't admitted. She wasn't even there for midnight, and she had the test.
All right.
Yeah.
Good to know.
Yeah. And Dr. Brus, I know that here at the Arlington, we do have COVID screenings on both sides of the community. And then we also have COVID tests for all of our residents coming into our skilled community too.
Right. So as I said earlier, all residents that are coming in, all patients coming in from the hospital are being tested day of discharge with the rapid test at the actual hospital itself. We are following all state guidelines as far as skilled nursing and long-term care. All of us were tested last week by the Department of Health. Before anyone is able to enter the building, which I'm sure is standard across any building here in the state, you are screened. You're screened with the CDC questionnaire. You are screened with temperature checks. We go through that every time we enter this building. We go through that screening process as well.
Yes, it's very important, and you see that more and more happening now. Another question that just came up that I'm grabbing over from Facebook was for a geriatric care manager. How does someone go about finding a geriatric care manager, and what's the average cost of that?
Okay, so there's a couple ways that you can get you can determine a geriatric care manager. The global way is going on aginglifecare.com, which will bring you it all throughout the nation. You can then put your zip code in, it will bring it up. Every care manager that's an aging life care professional are certified. We all have certain educational levels. We all practice the ethics and standards of the committee. There's a few care management agencies in Naples. I would recommend them all. We all belong to the same association. I particularly like mine because it's a team and I'm part of it. But the average cost, it is private pay. Occasionally you'll have a long-term care insurance that will pay a portion of it, or like the assessment. The general rule of thumb is about $100 to $150 an hour. And again, we don't do the direct hands-on care, we coordinate the care. We set up a plan and then oversee the plan.
Okay, wonderful. Does anyone else have any other additional questions? You can send me a chat, I'm just checking right now, or you can raise your hand and we'll make sure that we get you on. Just checking. Okay. Well, thank you all for joining today. I want each of you as the panelists just to let everyone know how they can get in touch with you and your contact information. So I'm going to start with Rich Chechilo from Comfort Keepers.
Sure. There's a couple ways you can get a hold of us. Our phone number, our main phone number is 239-590-8999. Or you can check out our website, which is comfortkeepers.com.
Okay, wonderful. And Colleen, if you can go next.
Sure. The office that manages that area is in the town of Estero. I have a direct number, 239-596-6003. But in order to even expedite things more, Holly Kreiter is our sales manager. Her phone number is 239-444-0800.
Okay. And I have Joanne.
So our direct line is 239-653-7882. It's staffed 24/7. We are open all the time because we deal with crises. I'll give you my email. The website is you can look up My Care Manager. It's all one word. My direct email is Joanne, JOANNE, at mycaremanagernaples.com, all one word.
Okay, great. And Dr. Brus, if you don't mind, I'll let everyone know how they can get in touch with us here at the Arlington, so we don't give out your personal email address. It is thearlington.org, which is our website. You can also contact us at 239-307-3100. And you can ask for admissions for Skilled with Christina, or if you want some information more on healthcare, assisted living, or memory care, that would be Robin Desmond. I have one more question that just came through. And she said, this is for Rich and Colleen. Oftentimes people say that private duty will come in when Medicare home health is done. Can they be both present at the same time in the home? Oh, did I lose everybody?
Colleen, you're on mute again.
Oh, I just
There you go.
I'm an old dog. The new trick thing. My apologies. We coexist constantly. As a matter of fact, I don't know that we do the job as well often when we don't have each other to work with. So, excuse me, in fact, yes, they have nothing to do with each other. It's private pay and it's Medicare reimbursement. So there are no reasons for them to be mutually exclusive.
Wonderful. Well, thank you all again so much for coming on today. I want to let you know about some of our upcoming events that we have because we're continuously educating our community with events like this. If there's something that you would like, please email me. You can feel free to do that as well. My email is felicia.saraceno@lulife.org, or you can also send me a message on our Facebook page, which is Facebook/Oakton Place at Arlington. Couple of upcoming events this month. I have a real estate market post-COVID update that's going to be next week on the 18th at 11 a.m. and David Ward from Southwest Florida Real Estate Group is going to be joining us for that one. And then on the 25th of June, we have long-term care strategies with Conrad Brus of K Press Advisory LLC. We also will be doing a follow-up event to this event, which will be how to prepare for your upcoming surgery and some tips on that for you too. So we'll have those details shortly. You can register for all of our events on our Facebook page, which is Oakton Place at the Arlington. You can put that in the search bar. But once again, you can contact the Arlington at 239-307-3100. This will also be up on our YouTube page, which we will share. And if you need some contact information for any one of our presenters, you can also feel free to shoot us a message and we would gladly connect you as well. So thank you all so much. Huge thanks to our panelists. We couldn't have done this without you, and we really appreciate you sharing your knowledge during this busy season.
Thank you for the opportunity. Great talking to everyone.
Yes, thank you very much.
Thank you, Felicia.
Thank you.
Bye-bye.
Okay. Well, everybody have a wonderful day.
You too.